and oh, thank you for that. I always forget. And the last three cases will be presented by Salim. So case AL1, 53-year-old, presented with a skin-colored papule in the left nostril. And there were a couple of clinical differentials given. And it was a shave biopsy and no immunohistochemistry had been done. So these were the sections that were provided. And I think what we can immediately see that this is a fairly circumscribed tumor. I think that's something which perhaps we can all agree. And that's important because when we come to the differential, that's something which a lot of people had commented on, which has, swayed them one way or the other. There's no connection to the surface. It's a dermal lesion. It's clearly a spindle cell tumor. Again, the circumscription. When we go in high power, it is neural. I think it's got these nice wavy, spindly cells. There is a bit of a fibrillary matrix in the background. I did notice some mast cells knocking around. So as you would have seen, neurofibroma is one of the top differentials, and certainly in high power, one would think about that. The cellularity was variable, some places a bit more cellular than others. I didn't really see very well-defined palisading or verrucae bodies in this section. And again, going back to the edges of the lesion, it is circumscribed. Whether it is encapsulated, partially encapsulated, you can make a decision on that. Some people have commented on the presence of retraction. So you can sort of try and assess if you think that's some evidence of retraction, again, that edge of that lesion. Okay, so if you look at the split of diagnoses, the original diagnosis was a neurofibroma, but we've not quite reached the 75% threshold in this case. So neurofibroma is the most popular diagnosis, hitting 65.5%. The next most popular is solitary circumscribed neuroma, also called as palisaded encapsulated neuroma. And between the two, actually, that's nearly 95% of all the votes. So I think the vast majority have gone for one or the other. And I'll just show you a snapshot of comments. A lot of people commenting on the problem in distinguishing these two. And then there is a much smaller minority who have gone for other entities like schwannoma, some for angiofibroma, dermatofibroma, and then the less common ones we've clubbed together under category 7. So before I open it up for discussion, I thought we'll just look at some of the comments which people have put. I think the main problem seems to be the neurofibroma versus solitary circumscribed neuroma. The circumscription has tended to sway people more towards a solitary circumscribed neuroma. A lot of people felt that it needed an immunohistochemical panel. A diffuse S100 positivity, for example, would have favored solitary circumscribed neuroma. Again, the sort of same problem with the differential diagnosis. The site, people have commented upon the face favoring a solitary circumscribed neuroma. Others have felt that actually it is quite diffuse and neurofibroma-like. I think a lot of comments about the need for immunostains, and generally the ones that people have recommended are S100, EMA, CD34, Claudin. Okay, so back to the table. So I think thoughts from the group in terms of what they thought was the diagnosis here, and also how would we perhaps make this a scoring case, if at all. Okay.
I was going to monitor the chat if other people could monitor the hands up type of thing.
Okay.
Okay. So I can see that Nastasia's made a comment. No clefts, and it is ill-defined. So she doesn't think it fits with a solitary circumscribed neuroma, even despite the location.
Some people are having problems with the OT.
Alan, clefting with surrounding stroma, also typical of, so almost the opposite view there. Richard, solitary circumscribed neuroma. Suggestion to merge 1 and 2 has come up. Andrew Boone, merge all nerve sheath tumors.
Are people able to raise their hands? I'm not able to find the hand function. Is it under React?
We can't find the hand function here.
Yeah, even I was struggling. Or is it under more?
I think it's if you the short key is Alt Y, if I remember correctly.
Alt Y.
Yeah, I think so. Let me double check.
Yeah. It is there, raise hand under React.
Under which?
It's at the bottom, towards the bottom of the React. It's a separate one, raise hand.
I don't have it either. I don't know why.
Oh.
In the chat.
There.
It's not in the main panel, but it's underneath raise hand.
Hmm.
Yeah.
Well,
Not-
if people
not-
can find
not
it,
there.
please. Yeah. But Patrick, did you want to say something?
Yeah, I
Okay.
just wanted to say, from a morphological point of view, I think, it's got features that are overlapping between neurofibroma and solitary circumscribed neuroma.
Okay.
And I would really suggest combining those two to make it a scoring case, especially when you don't have immunos to see whether there is a capsule there, and also whether it's just diffusely positive for S100 or not.
Okay. Thanks, Patrick. So in a case like this, would you have done immunos?
Well, if I think I need to distinguish between the two, yes, I would do the immunos to try to help in the distinction. Yeah.
Okay. Any other thoughts?
I was thinking more in a real life situation. Is this the case you're going to spend labs money on immuno? You might just say it could be a bit of both, or that ballpark.
Yeah. Yeah. And both are benign, I suppose, in terms of
Yeah.
management. So lots more comments coming through.
Some are talking about looking for nerve bundles, nerve twigs as a distinguishing feature.
You would find them in both, so the axons. So it's
Yeah,
not,
that's
not-
more
not
helpful
very-
from a distinction from a schwannoma,
from a
isn't it?
schwannoma point of view,
Mm.
but yeah.
There is a suggestion for merging 1, 2, and 3 as well
Okay.
in the comments in the chat.
Generally seems to be 1 and 2.
Yes.
Okay, I think we can go for voting. Not many more comments are coming up. Eleni, you want to try hosting the
Yeah.
polls? Yeah.
So we vote for each one then.
Yeah, if you
Yeah.
launch AL1 poll, then it should hopefully work. Yeah.
Is it
Yeah,
showing?
that's
Just a reminder, only for full participants to vote, please, not for visitors to the meeting. And no comments on about diagnosis once we start the vote.
We have about 140 people so far have voted.
okay. So we've got 235.
Yeah.
Normally we get around 70-75% people voting.
We don't usually have a code for voting, Kundan. You should just be able to see the poll come up. It's my understanding.
Yeah. Yeah, I think we can end the poll, Eleni. It's not
Okay.
changing anymore.
Yep. Sharing results.
Okay. So score 1 for neurofibroma, score 1 for solitary circumscribed neuroma. Let me just move down.
I think everything else is 0.
Everything else is 0. Okay. All right. Okay. So that makes it a scoring case because both categories 1 and 2 have been given a score of 1. That's great. Thank you. So I think you can just close the window on your screens. Okay. So I just put together a short little presentation. So this is actually, I was remembering Ashok had done a talk on cutaneous dural tumors, and actually he had talked in depth about the differential and how to approach it. So this talk is actually still available on the EQA website. So if you go under reference data, you'll have documents, and under documents, This talk is still there in PDF format. So I was just looking through it yesterday. It's quite a nice sort of practical step-by-step approach of these tumors. And there's a nice table on the immunohistochemistry, how that can help. But like Patrick said, solitary circumscribed neuroma and neurofibroma do have some overlapping features, but the S100 tends to be quite diffuse with solitary circumscribed neuroma, so that might have been helpful. Of course, the EMA would have also highlighted a capsule. And if you look in the WHO fascicle, it considers circumscription as an essential criteria, but encapsulation is more of a desirable criteria. And there are some nice pictures as well of solitary circumscribed neuroma showing diffuse S100 positivity, the axons picked up with the neurofilament protein, and EMA highlighting a bit of the capsule. But of course, one could argue whether we need so many stains to make a diagnosis of a benign tumor, but these are the stains that would help make the distinction in difficult cases. Okay, so let's move on to case AL2. So this was a 52-year-old male, and the history provided was of multiple lichenified plaques on the trunk and limbs. And the biopsy was an incisional biopsy. There was quite leading special stains provided. So the Congo red was weakly positive. Thioflavin T was strong on immunofluorescence, and AE1, AE3 was also weakly positive. And if you look at the biopsy, this was a nice incisional biopsy. And what was immediately apparent was that the changes were confined to the superficial dermis with lots of these pigmented macrophages. And then when you went in high power, you start noticing these eosinophilic deposits in the papillary dermis. Some of them had this faceted appearance. And again, the very prominent pigmented melanophages. I didn't see any convincing interface change, and overall the inflammation was also quite minimal. Just some more pictures. It was really quite a lovely case, and obviously with that leading special stain history that was provided, I think most people didn't have a problem with amyloidosis. But I think what struck me is, and I'd be interested to know what other people's views are, but sometimes, I wonder about amyloidosis, and I find it difficult to distinguish between just colloid bodies. But a case like this, I think, just shows us when you have a good classical example, it is quite obvious, really. And this is the split of diagnosis we had, and clearly everybody recognized that there was amyloidosis. The vast majority going for lichen amyloidosis, but also quite many going for macular, others preferring to use a more general primary cutaneous amyloidosis, just amyloidosis. So quite a range there, but basically from 1 to 7 is all different forms of amyloidosis. Prior to the meeting, me, Salim, and Eleni did wonder whether we should combine some of these, but then we thought it's probably best left to the membership to make a decision on whether what score should be given to each of these. There are sort of subtle minor differences between all of these categories. And just a snapshot of comments, I think the general trend was people felt that both lichen and macular amyloidosis would show similar features, and the distinction requires clinical correlation. Obviously mentioning about the distribution of the lesions, the morphology, and the symptoms, which would help in the subclassification. Someone commenting that actually there can be overlap, and there is a term of biphasic amyloidosis also used. This was interesting. Somebody said they considered calling it localized cutaneous amyloidosis because the distinction between macular and lichen can be difficult. But they made a point that localized cutaneous amyloidosis also includes nodular type, and that perhaps may not be an appropriate diagnosis. We know that nodular tends to be much more sort of deep-seated in the dermis, much more bigger deposits. Others felt that the main bit was to rule out a systemic process. Otherwise, it was a primary cutaneous localized amyloidosis. So that was the general flavor of comments. But quite a lovely example, I have to say. So thank you to the submitting pathologist. It's not something that we have seen before in the EQA, I don't think. So a really nice case. What are the comments coming through?
Quite a mixture. Some people, I think everyone's concluding it's amyloid. There's some discussion about which stains work best in amyloid, interestingly. Okay. Not too much discussion about subtypes, interestingly. It's more about the diagnosis of amyloid generally.
Mm.
Yeah.
I have to agree. I don't find Congo red very helpful. It's very rare to get Congo red positivity.
We did actually study this, and I can say that maybe I don't think it influences the vote, but we've done a study in Dorchester, systematically comparing all of the stains, the different
Okay.
keratins, and Congo red. I might put the link in afterwards, but the 34BE12 in our lab was consistently the best stain for cutaneous amyloid, and
Better
Congo
than
red is
CK5/6. Because I
yeah
tend to use it. Okay.
30. Obviously, Congo red is useless.
Hmm. Okay, so what about, yeah, I think the discussion is more on that. So what about the different subtypes? What would people
So
accept?
one comment there, somebody has suggested that 6 is not really an appropriate score, a correct answer.
Okay, thoughts on that? So is that your paper then, Salim, the one in American Journal?
Yeah, I'll try and find the link later and put it in.
Okay, that's helpful to know.
Arjun's got hand up.
Yeah, Arjun?
Hi, good morning. I just wanted to make the comment. My understanding is that it's a bit of a mix of two different pathophysiologies. Lichen amyloidosis and macular amyloidosis, we are using the term amyloidosis to denote the retention of any protein within the dermis, and they can be because of diverse etiologies. Lichen amyloidosis and macular amyloidosis represent the cytoskeletal, like quite literally, like you were saying, colloid bodies. So they represent accumulation of cytoskeletal elements of mummified dead keratinocytes. So they are pathophysiologically distinct from the systemic circulating proteins that get deposited in the skin. So that's why lichen amyloidosis and macular amyloidosis stain positive with high molecular weight cytokeratins. And that's why they are subepidermal, because they represent chronic persistent subacute epidermal injury with a very inconspicuous immune attack that is killing off these epidermal cells, and they are falling down and raining down and accumulating. Whereas all the other amyloidosis, the primary cutaneous nodulars, tend to be deeper. They tend to be not of high molecular weight cytokeratins because they don't arise from cellular damage, but they have the other proteins, circulating P proteins and AL proteins. Those are Congo red positive. So it makes complete sense that lichen amyloidosis and macular amyloidosis, being a different type of mummified non-absorbable protein, is negative for Congo red, whereas immunohistochemistry for cytoskeletal proteins will be positive to distinguish them. So the reason I'm saying this is I think 1 and 2 are mergeable, but if you merge the other ones, there's a potential of confusing important clinical distinctions between these distinct pathophysiological diseases. Thank you.
Thanks, Arjun.
That's a very interesting thought. I was in my head, amyloidosis means that whatever derived source of protein gets the beta pleated sheet structure. This is what defines amyloid. So it can be different origin. And we do have experience with that as well locally, and so. Congo red does come up in our staining, and we do see it under the microscope and with polarizing microscopy, but also in the immunofluorescence where it's green. It's red. So under polarizing microscopy, we see the apple green, and if you put it under the immunofluorescence microscope, it looks red. But it's not reliable always because it can also be false positive or false negative, as we know. Just another
Thanks,
thought on
thanks,
that.
Alini. That's interesting. Yeah, in our experience, we've not found Congo red very helpful, but you're right. I mean, it is ultimately the beta pleated structure, isn't it?
There's a few comments coming about to influence or relating to the voting. So some are saying 1 to 5 potentially might all be correct.
Yeah.
I think a lot of people feel that 6. We've got
Yeah.
Magad doesn't feel 6 should score. Reno
This-
mentions that subtypes are often mixed clinically. So although we may try and distinguish here, you can even get some overlap clinically.
I wonder if some people had, an option issue on the drop-down list and went for the other varieties.
There's a question about 8, whether, not 8, sorry, 7. Whether 7 is the same. And actually, we normally combine synonyms, but we weren't sure about this. But from whatever I've read, papular is apparently the same as lichen amyloidosis. It's only 0.2%, but perhaps that does deserve the same score. So the main question seems to be about the systemic one, 6, and I think some debate about primary cutaneous and localized cutaneous. I think we'll have to go to vote and see what people say.
So I'm going to launch the poll then.
Yeah, thanks.
Oh, about 150, 160 people voting at the moment.
It's still moving.
It's
So.
still going, yeah.
Yeah.
People are passionate about amyloid. That's great.
Interestingly, sorry, I'm just putting one more comment. Interestingly, you see a very subtle form of this in notalgia paresthetica on the back, where you get very subtle post-inflammatory changes and occasional sort of colloid milium amyloid bodies dropping down. And you can see a very florid example, but a neoplastic version of this as a single lesion in regressed squamous proliferations. So they will leave behind, it'll be a single nodule, and it'll leave behind a lot of post-inflammatory change with huge aggregates of these bodies, which will be positive for exactly the same immunohistochemistry. I've never tried a Congo red on it, but yeah. So just wanted to add that.
Thanks, Arjun. I mean, obviously this comment was fine, but generally when we are voting, please do refrain from not commenting. But of course, this wasn't. This was just an interesting comment.
I think I'm going
Not
to
really
end poll
moved now. Yeah, I think
Yeah.
we're finishing now.
Okay, so
Okay, so lichen amyloidosis 1, macular 1, primary cutaneous 1, just amyloidosis has also scraped into 1. Is that correct? Yeah.
Yep.
And then localized cutaneous 1, systemic gets a 0.
0.
Papular 1, and everything else 0.
Yep.
Yeah, I think that's a very sensible vote. Okay. Okay, thank you, everyone. Right, so we'll move on to the next case. Oh, this was just a quick picture that I took from DermNet because of the discussion, about the clinical distinction between lichen and macula. So lichen tends to be more in the extremities with the sort of papular configuration, whereas macular amyloidosis tends to be quite flat, pigment-free sort of a change, so often presenting with hyperpigmented patches. And of course, there is a sort of biphasic or overlap and a nodular amyloidosis as well within the primary cutaneous amyloidosis group. Okay, so moving on to case AL3, this was an 82-year-old female with an excision of a lesion on the right buttock, clinical query of melanoma. No immunohistochemical stains had been provided. And this is the histology. So you could see there is a well-circumscribed tumor in the dermis, forming a exophytic sort of pattern. It's mostly solid with focal cystic areas, no surface connection. And then when you go in hyper, you start seeing perhaps mainly two population of cells. So one which have a bit of a clear cytoplasm, and the others which are quite monomorphic, bland, small ovoid cells. There was also hyalinized stroma, which was quite striking. Again, that mixture of two types of cells. I think one of the main differentials in this case is a poroid tumor. So I think it'll be good for people to try and assess whether some of these cells look poroid in type. It was overall quite a bland tumor. I didn't really find any mitoses, no necrosis, not much ATP at all. Okay, so that is a split. So this the original diagnosis was a clear cell hydradenoма, and the most popular diagnosis is that of a hydradenoma, and that does cross the 75% threshold, making this a scoring case. The main differential is a poroid hydradenoma, which had a popularity score of 9.5%. Dermal duct tumor, which is also considered a subtype of poroma, that was 3.8%. And then some of these other adnexal tumors. If you just look at the snapshot of comments, there weren't that many actually in this case. I think the people who went for hydradenoma didn't really put many comments, but the ones who went for poroid hydradenoma or poroid tumors have put in comments to defend their diagnosis. Many people felt that the cells were perhaps slightly poroid, commenting on these two cell types, basaloid peripherally and then smaller clusters of paler cells centrally. People did identify some ductal structures, but I didn't really find that many. Some people have considered a dermal duct tumor as well. So yeah, not that many comments in this case. So back to this differential. So I think it's a scoring case, but any defense for the other categories, particularly categories 2 and 3?
There are no comments yet on this one.
Okay,
on
people
the
are
chat.
thinking about it.
Just as a comment, there's genetic sort of subgroups of hydradenoma. Some of them do correlate with the morphology, depending on which translocation there is. So we can sort of now subcategorize these. I think the ones with the clear cell are, overlap with what we might have called conventional hydradenomas, whereas the poroid one is different, slightly different morphologically. There wasn't actually that much clear cell change, and there was a bit, wasn't there? But I'm not sure I would have called this really clear cell hydradenoma subtype.
I agree.
No one seems to have voted for that either, interestingly.
Yeah.
There's some comments coming through now. We've got some are suggesting 1 and 2 could be combined. Others are actually saying that poroid is not the same here, and this isn't typical of that. This case, so it's almost a difference of opinion there. Some feel that dermal duct tumor and poroid hydranoma should score. So just
there
different
is no
opinions,
need,
really. Yeah.
if
But
I
lots of people think 1 and 2 should score.
We don't need to merge anything, is that correct?
Yeah,
Because we
I think the
already
idea
have...
of we don't need to call it merging, but I think that people are implying that they think that 2 should score. That's really what my understanding of that would be.
Strictly speaking, yeah.
No cuticular cells. Yeah. Okay.
My understanding of dermal duct is it's usually more sort of multi-lobular sort of tumor in the dermis rather than
Yeah, and much more obvious duct formation than this one. I suppose in defense of poroid hydradenoma, usual hydradenomas show like a mixture of squamoid, apocrine, clear cells. This did seem to have 2 population of cells, and perhaps that made it look a bit more monomorphic. Okay, not that many comments coming through. I think we've got some really interesting cases coming up, so we can go fast on this one, I think.
Okay.
So let's go for voting.
Okay. So AL3. People are voting, about 145 we are. We don't need to vote for the first one because it's already
Yeah,
more than 75%,
yeah.
looking at the comments in the chat. There's some comments about whether this is a very easy case for EQA or nothing is too easy.
I think it's a good case.
Center,
It was a lovely example.
an interesting differential with,
Hmm.
I think it's stable now, so I will end the poll
Okay.
and share results. So it's 1 for poroid hidradenoma scoring. So
Okay.
dermal duct tumor
Oh, just about didn't make it.
didn't make it.
Okay. So it was
Everything else
quick.
is zero.
Everything else is 0.
Yeah.
Okay, perfect. Okay, thank you, everyone. So that's it from me for my 3 cases. So the next cases will be shared by Eleni. Do you want to share your screen?
Yep. Okay. So is it showing full screen now?
No.
Not yet. Still not.
No.
Should be now. Is that
Yeah.
okay? All right. So I'm going to present in cases 4 to 7, if I manage to move. So case 4 was a 53-year-old female patient with several month history of erythematous patches. She had a punch biopsy on the right upper arm, and the clinical differential was query lichen planus, query BCC. They called it patches, but maybe there was some more substance to the lesions. And there was a punch biopsy that included subcutis, and it showed a epidermis throughout the thickness of the dermis extending into the superficial subcutis, and the epidermis was not involved. And there was this inflammatory infiltrate that focally abuts the epidermis. It's mainly perivascular, maybe a little bit interstitial with some possible fibrosis in between, some more subtle blunt spindle cells, and some periadnexal extension, which does not leave a Gren zone around the adnexa, and then deeply again around vessels and going into the superficial adipose tissue. They're looking at the vessels themselves. They were small vessels with telangiectasia and some prominent mimicking hobnailing endothelium, but not really the epithelioid abundant eosinophilic or vacuolated cytoplasm that may have made some people think of the differential of angiolymphoid hyperplasia with eosinophilia. There was a mixed infiltrate with eosinophils, neutrophils, karyorectic debris, and again here a closer view, lots of karyorectic debris in between. But if we look around the vessels, and in the tissue between no real fibrinoid necrosis, not many extravasated red blood cells, and the inflammation was perivascular and maybe involving the wall of some vessels. Again, like a cross-cut of a vessel, but no fibrinoid necrosis really, and some partial involvement of this vessel, but it's a thin vessel and all the vessels of more thicker wall were not involved. And I'm mentioning this because there was a differential of portally arteritis nodosa that you may have seen in the scoring. And so there was quite a split of opinions here, but the majority were hovering around these differentials of vasculitis, leukocytoclastic vasculitis. People went for 36%, and erythema elevatum duodenum was the second favorite, which if added with granuloma fasciale or chronic fibrosing vasculitis would be about 20% of the differentials. And then urticarial vasculitis or neutrophilic dermatosis, palisaded neutrophilic granulomatous dermatitis, or focusing on the eosinophils, people considered Wells syndrome, and smaller differentials further down, as we will see in the comments. So people commented on the quality of the slide. Some found it very pale or pink, others found it good quality sections. Members wanted to know if special stains were done. There weren't done any or submitted with the case, but they would want to have seen PAS-D or EVG. And the main differential was around LCV, EED, and differentials based on the neutrophils that were present or the eosinophils. So comments about LCV were that this could represent a late stage leukocytoclastic vasculitis or an early resolving vasculitis, while the absence of fibrinoid necrosis with eosinophils made people think of urticarial vasculitis. Others thought this is an established lesion of EED or an early stage of this, and that there was a lack of clear correlation with the clinical, calling it a patch, which put some people off from the diagnosis, and others favored the more general term chronic fibrosing vasculitis. Based on the eosinophils, people considered drug, Circ, Strauss, Wells, or eosinophilic annular erythema, considering it, as one comment mentioned, a variant of Wells. And then other less likely probabilities of arthropod bite reactions, etc. And Sweets came up a lot with the presence of neutrophils or other neutrophilic dermatosis. The original diagnosis was erythema elevatum duodenum, and so we open to the membership for comments.
Yeah, could you put up the table again, Eleni, to see? Yeah, okay.
A few comments coming in. I think a lot of people think it's going to be difficult to get to the scoring case here. Some people did think about EED and maybe it didn't quite fit in some respects, too superficial, somebody says. Other people think it's classical EED.
What did you think about the clinical history? What was it? Erythematous patches, wasn't it?
Yeah.
Erythematous patches.
It's not a typical story.
Not typical for ED. Yeah, that put
Oh.
me off actually. Yeah, that didn't quite fit.
And the question is there actually vasculitis, you know, from what you showed it?
Yes.
There's karyorrhexis, but is there really bona fide vasculitis?
And not the typical history for vasculitis either.
Yeah.
You kind of get the feeling that whatever you end up calling this, the patient needs to be investigated for an underlying systemic process. That was my feeling about the case, even if you couldn't agree on the diagnosis. It's definitely the sort of histology where you want to know if have they got anything else underpinning this.
Yeah, I guess it's one that you go to a CPC meeting and you offer potential differentials, and it depends on the discussion and the clinical input.
Yeah. I think somebody's commented, Abhi has commented that almost all 1 to 14 appear good differentials just based on histology, and we would need a solid CPC. I agree entirely.
Good point. Yeah.
Yeah, we're not, none of those are actually completely wrong, nor completely right.
Mm. Some people are commenting on different appearance on the different platforms. Anastasia is saying they were showing better at Oxford while they looked maybe darker or pinker at Leeds and difficult to interpret, which is useful for us to know how people found the different
Yeah.
platforms.
Okay, we're not coming up with
Okay.
any suggestions in terms of how we could make this a scoring case, but I think we should still ask the question and then, yeah, whether this can be a scoring case.
So I don't seem to have that poll option here.
Somewhere down the bottom, perhaps, or
It's because I'm sharing. Okay.
Do you want me to
I
project?
could launch it if you.
Yeah.
I think if you could launch this one.
Okay, I'll launch one of these.
Yeah, you go ahead, Celine.
Okay, I've got it now, but yeah. Great. Thank you.
We're not going to get there.
Yeah. So.
Yeah, I
Is
think
the-
that's a clear answer.
Okay.
Non-scoring.
Right. Okay. Sorry. Yeah. I just thought that because we haven't had, we're discussing with Artie, we haven't seen ED as a proposed diagnosis in the scheme before. I would do a little bit of a very short slide to say that it's very reasonable that all the differentials come up, since all these entities that we discussed come under the vasculopathic reaction pattern. And the erythema elevatum duodenum, such as LCV, are classified under acute vasculitis and even neutrophilic dermatosis. As we know, there is a vasculopathic element. And just to show for people who haven't got experience with these diagnoses, that the typical scenario would be acral, symmetrical, persistent, violaceous papules, plaques, or nodules. And the histology is very variable depending on the phase of the lesion. So in early stage, it can be practically indistinguishable from leukocytoclastic vasculitis, although there may be less RBC extravasated red blood cells. And this is from a mixture from Whedon and Maki. Somebody's asking. And then established lesions will have neutrophils throughout the dermis, while if people want to differentiate from granuloma faciale or extrafacial granuloma faciale, EED tends to have more neutrophils versus granuloma faciale, which has more eosinophils. And typically a granzo from the epidermis and adnexa separates the infiltrating granuloma faciale, which we don't see in EED. And in the late stage, where both can overlap, there is this fascicle proliferation of spindle cells. Yes, this is a piece from Whedon, where it just says it's although it just reflects that there are overlapping features of vasculitis, and EED has prominent fibrinoid chains in vessel walls, and it's best included in acute vasculitis, despite the fact that otherwise it has a lot of histopathological features in common with the neutrophilic dermatosis group. So yeah, that's on that. And I'll move on to case 5 now. So a male 47-year-old with a new onset of generalized eruption with numerous small papules and a collarette of scale on the trunk and proximal extremities. Had a 2 mm punch biopsy, doesn't state exactly where from, if I'm not mistaken. There was epidermal changes that we can see on low power psoriasiform epidermal hyperplasia and a thickening of the corneal layer that looks a bit parakeratotic and maybe at the top conspicuated serum, crusting, a bit of cellularity. One wonders if there are inflammatory cells there and wonders if there are neutrophils within the upper layers of the epidermis and in that parakeratotic layer. Looking very closely, although as people have commented, this was a little bit difficult to identify the morphological features. Maybe a dyskeratotic cell, question mark, or not. Maybe extravasation of red blood cells within the epidermis or not, for people to make up their minds. And a superficial perivascular infiltrate, which may show a tight distribution around the vessels of lymphocytes and histiocytes mainly. And so there was again a split of opinions, but the majority were polarized around two main differentials. So about 35% of members considered pityriasis rosea as the main differential, and then about 50%, if we put them together, guttate psoriasis and psoriasis. We had other differentials such as pityriasis lichenoides, PRP, or gyrate erythemas, and then smaller differentials, one of which was syphilis, spongiotic dermatitis, etc. So the comments from the membership were that the section looked a bit thick or blurry on both leads and path portal. People couldn't make out whether there are neutrophils, but some favored the presence. And people wanted to know about PASD and levels. And there was an interesting comment about the use of AI in solving this conundrum with putting in the clinical, it came up with likely diagnosis pityriasis rosea and secondary syphilis coming up as an important differential. They both clinically share a collarette, which in syphilis is called Beats collarette. Other differentials, pityriasis rosea like drug eruption, guttate psoriasis, or pityriasis lichenoides chronica. So people were put off pityriasis rosea by a higher degree of psoriasiform epidermal hyperplasia and presence of neutrophils, and between the two differentials that for these reasons favored psoriasis, and given the distribution considered guttate psoriasis. Again, more comments reflecting the same. I think the submitted diagnosis was pityriasis rosea. So we are seeing some comments in the chat that pityriasis rosea is hardly ever biopsied. We don't see it very often because obviously it's a straightforward diagnosis to make clinically, and so it's maybe the atypical ones that may reach our microscope. Wide differential, Bandor, Monroe, loss of granular layer.
Yeah, can we have the table again, Eleni? Is there any way
Yeah.
of making this scoring?
So if we were to add the first three, it would be 67 plus 21. Would go
That would
above
be, yeah.
65,
Yeah.
75. If we're happy to consider two main differentials, I guess. Richard has an interesting comment about syphilis and the slender elongation of rete ridge is suggestive of syphilis.
Arjun, do you want to make a comment?
Thank you. I just wanted to say, in terms of pathophysiology, pityriasis rosea is a classical pityriaciform dermatosis where you should see mainly very discrete lymphocyte exocytosis, the occasional apoptotic epidermal cell, and then signs of increased turnover in terms of mild parakeratotic scale. And it's not strictly itchy, it can be itchy, which is the problem is that if the person excoriates it, then you get secondary impetiginization, and that's when it becomes difficult to morphologically distinguish it from psoriasis. But actually, pityriaciform disorders and psoriatic disorders are two completely separate families of inflammatory diseases. So I'm not very keen of combining them because pityriaciform diseases are immune-mediated incipient subacute epidermal injury being targeted, causing increased turnover, which presents as a diffuse sort of papular erythematous scaling rash. And they have a huge differential diagnosis, drugs, autoimmune diseases, infections, including syphilis, blah, blah, blah. Whereas psoriatic diseases belong to a completely different branch. So I personally wouldn't favor combining categories 1, 2, and 3 because 2 and 3 belong to a different subspecies of inflammatory disease. Thank you.
I quite like Lauren's comment. For inflammatory dermatosis, we need that CPC. And there is an option to submit clinical photographs now with these types of cases to allow a bit more correlation. That may allow us to get to scoring cases more frequently for some of these type of cases. So just to keep in mind that option when submitting cases. Obviously, you need the consent and everything of the patient.
Yeah, I think the general trend seems to be in the comments that I don't think people are in favor of combining or
Yes.
considering quite disparate entities as correct diagnosis.
It is also that would be the ideal clinical scenario, but it is true that this also reflects reality, as we often get very suboptimal clinical and we're called to make these calls.
I mean, that's an interesting comment from Lucas as well. Sometimes we do end up, so yeah, I think there's a distinction to be made between the EQA setting and where we're actually making a diagnosis. Obviously, these are two different entities, but sometimes in an EQA setting, based on the information available and based on the slide that we have, it might be that two very different diagnoses are also reasonable differentials. So there have been instances where we have agreed for a score of 1 for two completely different entities as well.
Exactly, yes. That's a very good point.
So that's, I think, more of a case-by-case sort of decision to be made. So yeah, I think it's up to the membership how they feel about this case.
We're going to have to make a decision whether we ask whether it's scoring or non-scoring, or just take a vote on the whole lot.
Okay.
Okay. Should we just go for vote then? Do you think that might be better? There aren't that many categories. It might be. I think let's go for vote. That would be
so
more
scoring
accurate.
versus non-scoring.
No. I think just full vote.
Just the whole AL5 poll.
Yeah.
Okay.
Because there seems to be a mixed view, isn't it? So better to just go for vote.
Okay. Polls.
I can launch it. AL5. There we go.
Okay, thanks.
So just to explain to everybody, just vote for it. How if we get multiple categories with more than score of 1 and they add up to more than 75%, then we will call it scoring. But if we end up with categories with 1.5 and 0 and not adding up to more than 75%, then it'll be non-scoring. That's a more fair way of assessing this case, I think.
We can probably end the poll now. I'm going to change the voting now, I don't think. Yeah.
We've got an interesting result.
Yeah.
Mm.
1, 2, and 3 are above 50%.
Okay, so they all get a score of 1. And that takes us to above 75%. So that's 67 plus 20. So that's nearly 87%. Does everything else get score of 0? Are there any 0.5s?
No, even syphilis didn't make it.
Okay. Okay.
Did psoriasis 4 make it? Because I can't see the scoring anymore, I'm afraid.
Oh, I'm
Just-
still sharing.
It's disappeared for me. It's just I've got
Oh.
some issue with my screen.
No, psoriasiform drug was 0.
Mm. So just 1, 2, and 3 score 1.
Psoriasiform was 0. There was psoriasiform keratosis, so
That was also 0, yeah.
yeah.
Okay,
Don't
so
think
just the
there
top.
anything
3.
else about psoriasiform on its own. Okay.
Okay, so that's
Right.
good. We got it scoring.
Yeah.
Okay, thank you. Thanks to the audience for making that decision for us.
So I just put a very I don't know how we are with time, but this just single slide again to show the typical presentation of pityriasis rosea, if it's helpful. And I guess what a learning point for me reading around this was, if things don't fit, also consider syphilis in the differential, despite what is the correct diagnosis. Even just raising and exploring it, it's worthwhile, as it is the great mimicker. So a typical case of pityriasis rosea would have an acute self-limited rash, which usually presents in winter and starts with a herald patch, so a larger lesion that does not last very long, so you might miss that important clue. And then the rash is papulosquamous, described as salmon pink with rose-colored collarette, which is inside the advancing edge of the lesions. And it has this typical Christmas tree distribution, which is that the long axis of the lesions align along the Blaschko lines and typically involves tract, neck, and proximal extremities. And then on histology, as Arjun mentioned, it belongs to the spongiotic reaction pattern with pityriaciform spongiosis. So there are foci of spongiosis with lymphocytes. There can be vesicles that can mimic Potrier microabscesses because they're mainly lymphocytes and fewer Langerhans cells. And they can have a coat sleeve infiltrate in the superficial vascular plexus, which mimics erythema annularis centrifugum, and in fact that can be indistinguishable from PR in some cases. And the other characteristic findings when they're there, it makes the diagnosis more easy, is that there are parakeratotic mounds which are slightly lifted and oblique. And there can be individual dyskeratotic keratinocytes and extravasation of red blood cells, which can extend within the epidermis. And in longer standing lesions, one can find eosinophils in the dermal infiltrate. Just that, and then moving on. Bipin
We've
has
got
raised hand.
comment from Bipin. Yeah.
Just so. Salute sign.
Yeah, thank you. Thank you, Eleni. Just a quick question to our dermatology colleagues. How often do you biopsy pityriasis rosea? Because in Leeds, we seldom see it because, it's diagnosed clinically. And in fact, I can't remember when I last saw the last pityriasis rosea, but we do tend to see gutted psoriasis.
Personally, I wouldn't biopsy either of them. I'd just wait to see if the guttate psoriasis is going to evolve into typical psoriasis. But that's only speaking for me. Most of these times, you just need to wait. Obviously, you need to rule out syphilis, though. That'll be serology, though.
Thank you, Salim. If we don't have any more questions, I'll move on with case 6. Which was a 47-year-old male, and the history was, says can feel a lump again at the site of recent surgery, feels tender at times, catches when shaves his scalp. Examination, scalp, nape of neck posteriorly, left side, small lump underneath scar, non-tender, excised, query small epidermoid cyst, or only fibrosis. and there was an excision for this from the nape of neck / scalp, occipital scalp. So there were 4 sections, and we saw skin with scarring, some dilated hair follicles or eccrine ducts maybe there, uncertain. And then within the scar, there was inflammation, and there was a striking predominance of plasma cells around the vessels. And you could see naked hair shafts, possibly phagocytosed by histiocytes. And then more of this at the edges or beyond the scarring, with histiocytic reaction around empty spaces, which reflects a space occupied by hair shaft. And then again, more of this follicular distraction along the length of the hair follicle with histiocytic reaction, abscess formation around hair shafts. And as there was one of the differentials submitted was that there was some melanocytic hyperplasia on top here, just some blunt, not very confluent, not very atypical melanocytes on the surface. And more of these granulomatous reactions focused around hair shafts. And here are the diagnostic categories. So the majority favored scarring, so which is the second option here, 50%, and 6% went for folliculitis keloidalis nuchae, and other differentials with less than 5% scoring for granulomatous inflammation, pseudofolliculitis, pilonidal sinus, fibroma, etc., plasma cell granuloma, epidermoid cyst, and others. So comments were that the appearances look like post-surgical changes. People were concerned about why so many plasma cells in a scar, and would consider light chain immuno for restriction, and CD56 to check the nature of these plasma cells. Mention of melanocytic hyperplasia. And people who favored acne keloidalis nuchae commented that the histology is nice for it. Perhaps better CPC would be needed to support the diagnosis. The submitted diagnosis was acne keloidalis nuchae. I'm going to go back to the table here and see what comments. So this was how the clinical history was submitted. I'm just reading the comments, and there was no mention of the original clinical and histology. But that might be an interesting point, a learning point here. So we don't have any more information about before and after, except for what is presented here, which we assume is what the submitting pathologist had at the time of reporting this.
I think it was such a lovely case of acne keloidalis. It was the history. I mean, even the site was classical. In fact, if we didn't have the history, I think more people would have thought of acne keloidalis. It was that history of a previous surgery, which, I think caused all the confusion. But equally, that's a real life scenario, isn't it? They might have done a previous biopsy, not knowing what the diagnosis was.
Yeah,
Arjun has got his hand up.
Thank you. I just wanted to say dense plasma cell infiltrates are very typical of chronic inflammation and ulceration on the head and neck, in the oral region, and in mucocutaneous junctions. So it often causes panic in sort of young training pathologists, but it's actually quite typical, even around the eye. And conjunctival. In these mucocutaneous junctions and the head and neck, if there's any long-standing inflammation, you can get quite dense and sometimes even binucleate plasma cells and things like that. Thank you.
Thanks, Arjun. I think some people are commenting that they would be emailing the clinician about this case, and that's true, isn't it? You wouldn't report this case without getting the full history, but it's certainly something that you would consider. But I also thought maybe it's not, I'm not sure how many people are familiar with this entity. It's not something that we've had in the EQA, at least in the past. In general, we've never had many alopecia cases. That's perhaps something to consider for people in the future. Now that we have digital only format, perhaps people might consider sending in some horizontal sections for alopecia. But I think that's it's a good start, really. Do we think there is any way of scoring this case? People are not happy with the idea of alopecias. I'm scaring people.
All good, Path.
Okay, not scoring 1 and 2 together would, okay.
Somebody's suggesting combining 1 and 4 or 1 and 2 to get to scoring.
1, 2, 4, or 1 and 2.
Yeah, 1, 2, and 4. So there's a few combinations that could make it scoring. It might be better to vote on this as well, if there are possibilities people feel.
Yeah.
Okay, so that's 6. So I'm going to launch the poll to vote on all of them. People are voting for each one. I'm wondering if people feel it was non-scoring, what they should be doing.
So if people think it's non-scoring, then they should only vote for one category. Like give a score of 1 to 1 category. That will make it non-scoring.
So we are about 170 people in, and people are still voting.
I think it will score.
I think I will end the poll now. So we've got 90% for score 1 and almost 80% for category 2.
It is scoring then.
It is scoring.
Okay. And everything else gets a 0?
Gets a 0, yep.
Okay.
People are asking whether we should ask if it was scoring versus non-scoring, but just to
That's
clarify on that, if there are lots of people suggesting a combination of voting that could make it scoring, we're kind of obliged to vote
Yeah.
on these cases.
Yeah. I think if people feel it's non-scoring, then they should put in the comment to make us ask that question about scoring and non-scoring. Generally, the comments seem to be that this could be a scoring case.
Okay.
Arjun?
Sorry, I just wanted to ask if you had to do a poll for scoring, would it not be better to do it before presenting and discussing the case, particularly what the diagnosis was, because that will bias the score. So after we discuss all the things about the case, if we then go to score, then we've introduced some degree of bias in how people score it, which will, if it does become a scoring case, could disadvantage others. I don't know. I'm just putting it out there. Thank you.
So the format of the meeting is that it always opens up for discussion. So I think everybody has a right to defend their diagnosis. Everybody is a participant here. So the format is that we open it up for discussion. People put in their comments or defend their diagnosis verbally or via the chat function, and then we go for voting. And the original diagnosis is actually there when we generate the table. It just comes out automatically anyways. And also, nothing to say that the original diagnosis is the right diagnosis. That's just what the submitting pathologist thought. So, yeah. But certainly, we don't try and do any formal presentations before the voting. That's always done after the voting, not to influence the vote. So it is entirely based on the opinion of the membership, which they are absolutely entitled to have and to present and to defend their diagnoses. But the question about whether we should have gone for a poll on scoring and non-scoring, that's an interesting one, actually, in this case. Okay, but I think people have voted, and that is what is the truth when it comes to the EQA. So let's move on to the next case then, Eleni.
Okay, yeah. So just
Can we just check before we move on? Can we go back to the poll? There was some comment about one of the categories. I don't know if we can retain that, or if we lost the poll. Somebody was asking about whether one of the categories should have scored, and I just wanted to.
I don't know if I can still share.
Category 4, they wanted to just clarify.
Okay.
I think we better do that if it's still available. We'll be able to go back potentially in the recording, but
share results.
It's category 4. We just need to check.
Oh yeah, you're right. Category 4 is actually 0.5.
Okay, yes.
28 and 29 added together is 0.5. So well spotted. Thank you for that.
Okay.
Just check if anything else fits with that.
Yep.
Everything else is clear cut. Yeah. Thank you. Thanks.
So I was thinking about this, how this could have been a learning point, have a learning point, and it might be that the previous surgery is related to the entity, and then it certainly has come to my practice that a couple of times the specimens from plastics, usually with no clinical context, come with this typical nape of neck, unclear history if it's an epidermoid cyst or not. And then you see scarring, and you can see ruptured hair follicles within scars as well. But perhaps the degree of follicular damage in combination with this dense fibrosis with plasma cells in this location, if not diagnostic, may prompt the orientation of the line of management in the correct direction. Otherwise, there may be a repeat of operations. I'm not going to dwell more on that, but that was something I found interesting from this case. So AL7, and I'm mentioning that after the voting. So the seventh case that and last for me was a 53-year-old male patient with a pigmented nodular lesion on the lower outer helix of the left ear. And it was a wedge excision with a compound melanocytic proliferation with a bit of epidermal hyperplasia on one side or maybe in the center. This is one edge of the lesion to see how well circumscribed it was. It shows a bit of epidermal hyperplasia and the junctional component there. And then within the lesion, there was involvement of the hyperplastic epidermis, and it can be quite tricky to see how much of that can be an in situ component or how much can be within the dermis, in situ I should say junctional, and how much is dermal. And then the morphology of the melanocytes appears to be somewhat uniform, with areas though showing more spindling with vesicular nuclei, basophilic nucleoli, others a little bit more rounded, maybe smaller, some degree of maturation potentially at the deep end for people to judge, but admixed with larger cells in the same areas. And then on the opposite side, a little bit of a different morphology with more nesting, pigmented nests with spindling. And then vesicular nuclei, variably prominent nucleoli. And again, similar morphology, some more epithelioid cells admixed within the other cell types that we saw. And so the responses were 85% went for invasive melanoma, clumping all variants together. Some members considered a typical Spitz tumor or stump or Spitz melanocytoma, or Spitz melanoma, that is a distinct category, and other benign differentials, one combined melanoma and squamous cell carcinoma, and in situ melanoma, and other benign differentials, or variable other subtypes clumped together in the other category. The submitting diagnosis was malignant melanoma. The comments were that people wanted to have some more workup on this case, including immunohistochemistry, particularly the melanocytic markers, PRAME, and Spitz lineage immuno, molecular analysis, NGS, a case that would be shared with colleagues. Some comments considering the differential between spitzoid or Spitz. I thought that it does look spitzoid, but the patient is too old and there is asymmetry, no maturation. There are spitzoid features, but second, more epithelioid, non-maturing clone. People saw pagetoid spread, lentiginous architecture, too much atypia for special site or Spitz. It's on the ear, favoring melanoma. Special site nevus considered, atypical Spitz tumors favored, and as a main differential pending molecular testing such as HRAS or knowing the BRAF status. I don't know if people have started commenting on the chat.
Alan doesn't feel it looked particularly spitzoid. Alan Evans.
Okay.
Clearly a difficult case. Ear is a special site where spitzoid morphology is common anyway. Another comment. Yeah, lots of people saying ear can be a bit spitzoid.
Can we look at the table again, Eleni?
Yep. So about 8% considered a typical Spitz tumor and 2% Spitz melanoma, another 2% Spitz nevus. So in total, about 13% went for, or 12% went for a Spitz lineage in one way or another.
Did you find mitosis, Eleni? Sorry, I didn't
I think I may have found one. I didn't show. It was very difficult to find mitosis, actually. It would have been easier if there were.
Sarah McDonald found a mitosis.
Yeah, I found one mitosis as well, definitely.
Yeah, I should have put it on. I didn't. Yep.
I mean, it has crossed the threshold quite sort of clearly, 85%. And so the vast majority did go for a melanoma in spite of all the problems with this case. But there is, although it's a minority, but it's a significant minority which has gone for atypical SPIDs and invasive SPIDs as well. So in terms of voting, we won't be voting on category 1. That is the correct diagnosis. It's crossed the 75% threshold, so that gets a score of 1. But if people want to defend any of the other diagnoses, I think this is the time to put their thoughts and comments.
I would like to make a comment, which is in defense of category 3. which has
Okay.
nothing to do with how I voted. To really subtype melanomas, we need molecular. So arguably any sort of melanoma is not really wrong here if it's about
Yeah.
subtyping.
Yeah, and we did wonder about combining it with category 1, but we just left it separate for the audience to decide. But I agree. That is,
Yeah, the
in
only
terms of
problem is
management, that's still invasive melanoma.
category 6 is a bit of an issue because is this what we would consider as an acral site, the ear? That's a bit debatable.
But I suppose in terms of management, that's still telling the clinician that it's an invasive melanoma. The terminology may not be exactly correct. The combined tumor, the SCC with the melanoma, that was a bit surprising. I wonder if that was an error in picking up from the drop-down. Maybe that's something we could get rid of from the...
Yeah, I don't know, because there was a comment as well about that.
Okay. So they genuinely thought it was...
I think so. Pseudoepitheliomatous hyperplasia can be quite tricky sometimes, but
okay.
I'm not sure here there was enough to go that way.
Okay, somebody saying not lentigo maligna type, more than one deep mitosis. Andrew saw more than one deep. Naveen is in favor of category 1 and 3 being correct.
Some comments sort of trying to defend category 2, that this sort of case would need more of a workup, and that could still be a differential. So I think we should just recognize those comments.
Somebody's asking, someone tell us a clear-cut definition of SPIDS morphology. So that's a loaded question. Bipin is going to talk to us about SPIDSoid lesions. Maybe thoughts from Bipin and Will about this case would be helpful.
I mean, can I have a go, Arti?
Yeah, Bipin, please.
Yeah. Look, the WHO has divided, tumors into those 9 different classes based on, the sun exposure, the degree of elastosis, and based on molecular pathways. Now, when we look at a melanocytic lesion, the first thing we do is, where would you fit this in? Is it within the conventional category? Is it within the SPITS category? Is it within the blue? Is it within the DPN? Is it within the BAP1? Now, the question we need to ask is, does that lesion remind us of a classical Spitz nevus? Or does it more, remind us of a conventional lesion? So, I mean, I personally felt the morphology fitted into a conventional lesion. And some of it I'm going to address in the next presentation. And then looking at the morphology, I didn't have an issue as to whether it's a melanoma or not. The other bit I generally look at is melanocyte density and chromatin texture. So if I see variable chromatin texture across, the cells on a horizontal plane, I get very worried.
Would you have done immunohistochemistry on this case, Bipin?
I mean, it's different because I know there are many colleagues here. But the thing is, here we see a lot of melanoma. So on this case, I wouldn't. But I can see, when I get cases from different places that people do tend to do. So I think it all depends on, how many cases you see on a weekly or monthly basis. So the more you see, I think the more confident you are.
Okay, thanks, Bipin.
Arjun?
Thank you. Just on that point of chromatin texture, which is such a good point, I just wanted to highlight something. So a very similar criteria that I use is what I call horizontal concordance and vertical concordance, where in vertical concordance, as you go down the melanocytic lesion from the epidermis down into the dermis, if you see different clones at the same level doing different things. So it's a form of assessing clonal asymmetry or clonal instability. So it might be a difference in chromatin structure. It might be really nevoid hyperchromatic cells at one end and very large epithelioid cells at the other end. And the same thing in the other axis, which is vertical asymmetry. So if you go from the center outwards on both sides, and if you find on one side there is a subclone which is dramatically showing abrupt changes in cytomorphology, then that's something to worry about, because it's saying that the neoplastic clone, which clearly evolved from a single stem cell, melanocytic cell, is changing, is mutating and changing its spots very frequently, not just as it spreads out radially, but as it's supposed to mature down. That encompasses the same thing as dismaturation as well. So I just wanted to sort of say that was a really good observation, a very useful point that Bipin put across. Thank you.
Lots of comments about what is a spidzoid, SPIDS type melanoma. And I think that is the crux of the question, isn't it? I mean, I know about the cytological atypia, but then if we were to put this tumor in a SPIDS category, we automatically start accepting so much more cytological atypia than we would in a conventional. But I think this case highlights that always deciding whether the tumor belongs to a SPIDS category or not, or to a conventional, can be so tricky. That's the first step, but that itself is so tricky at times. Okay, I think we can go for vote then, isn't it? So we won't be voting on the first category. That is the correct diagnosis, but from category 2 onwards.
Okay. The numbering starts from 1, but they are
Yeah.
category 2, etc.
Yeah.
No one is voting yet.
People are thinking. I like that. People are giving thought.
Some people can't see voting.
Well, it's
I'm
there.
not sure if if there is access by a phone or whether that plays a role. It's a Zoom poll. I think that's different to a Menti. It's not a Menti link.
And don't vote if you're not a scoring member, please.
Yes, and interesting. Okay, I'm gonna comment on after the voting. Richard has put an interesting comment. So I think I will stop now. It's 100, almost 180 people. Okay, just one made the cut. Sharing results. So case 1 is not a typical SPIDS tumor is a 0, if I'm correct.
Yeah.
It doesn't make, yeah. 2 is score of, so it's more than 50%, so it's score 1.
1, yeah.
And then 3, 4 are 0, and 5 is 0.5.
Yeah.
Okay.
Okay.
6, 7, 8, 9 are 0.
Yeah.
Okay.
Cool.
That's very sensible voting. Thank you.
Yep.
I'm going to share my screen now.
I'll stop sharing.
Is that working for people?
Yeah,
It's
it's not full screen.
Yeah, it's full screen now.
Okay, perfect. So I'm doing cases 8 to 10. Case 8, story was 48-year-old male, left foot papilloma, excision specimen, and there were immunoslides which were scanned and available on all the platforms. We'll talk a little bit about those particular immunos as we go through. We were told the CD34 was negative, and the submitting pathologist diagnosed as neurothekioma. This is the histology. I've actually taken my images from the PATH portal mainly, but there are some other images I've brought in. So it's sort of a polypoid exophytic lesion. There's a bit of hyperkeratosis and mild epidermal hyperplasia. It's mainly a sort of a dermal lesion. You can see the multilobulated nature with fibrotic stroma at that low power. And the lobules are comprising these myxoid areas with cellularity. The cells are sort of delicate, slightly spindled cells with this background myxoid element. That's the high power. The cells, the nuclei look fairly bland. And then some areas not quite so cellular within these lobules, and you can see the surrounding fibrotic stroma. There were some areas where there was a bit more sort of degenerative change. And this is probably relevant to the voting, but there were definitely some lobules that were a bit more cellular and less myxoid. This is an example here. You can sort of see that transition to adjacent sort of lower cellularity. The cells are still bland in these areas though, but definitely higher cellularity. And these are the immunos from RCPath portal. So the MNF looked like it was only staining the epidermis and sweat ducts. This is the SOX10, which is definitely staining the cells within those lobules, quite strongly positive. S100 similarly positive. And this is from the RCPath portal. This is the GFAP, and it also seems to be staining the cells quite well. However, and this was commented upon, the GFAP from the Oxford portal, the Leeds was positive, but the Oxford portal, it appears that the GFAP is negative. And I think that did certainly affect some people. So this was the Leeds one, GFAP was positive. So it was just the Oxford one where there seems to be an issue. I presume it's either the wrong slide or something. There's something that's happened there. We've only discovered that really after reviewing this case. I'm just going to take some other comments. So some broad themes were some of the participants felt that the immunopanel was incomplete and they would have done more stains. I think a lot of people were going for this nerve sheath myxoma, but they were alluding to the fact that we shouldn't necessarily be calling it neurothekioma anymore. We're now distinguishing from that. So the classic, it used to be called classic or myxoid variant neurothekioma, but it's not really recommended in terms of the WHO. So these are comments from the participants. I'm not trying to influence the vote. Whereas, other people did comment upon the more cellular areas, but also that it was still showing the immunoprofile that we would expect in a nerve sheath myxoma, but definitely some more cellular areas. And then we had this issue with the GFAP, which some of the participants commented upon. And of course, if you only looked at the Oxford portal, that would be a problem. So, for example, the top comment, GFAP negativity is not typical, presumably, of the nerve sheath myxoma. Some have actually recognized that there is that discrepancy if they've gone into different portals, which is good. They've recognized that. There was a whole sort of group of comments sort of thinking about other entities here, some of the other nerve sheath tumors such as schwannoma or myxoid neurofibroma in the differential diagnosis. And even some comments thinking that this could be a low-grade malignant peripheral nerve sheath tumor. and then some comments about other differentials, angiomyxoma, acral mix of inflammatory fibrosis, and that was apparently an opinion from an expert. So that's the spread of votes. So we're going to get a scoring case anyway, because the first category is already over 75%. In our EQA dropdown, it still calls it brackets neurothekioma. We could reflect upon that for updating our EQA light dropdown if people want to update it afterwards. But we've got to think about, in terms of voting, these other categories and whether there's any merit in any of those. Interestingly, the original diagnosis was neurothekioma, even if we don't think that's necessarily a good term anymore. So out for comments.
So, Salim, did you have a look at the WHO? What is the correct
Yes, I have.
terminology?
I was going to show that afterwards because I didn't want to influence the vote, but
Okay.
I can tell you that one of the participants has already commented upon that, and I did share that comment. So the WHO has recommended we do not use the term neurothekioma anymore, particularly to avoid confusion. Some of the textbooks are still, maybe they're out of date, you could argue, but I can tell you that McKee, for example, it's still referred to as brackets neurothekioma. In fact, if you look at the index to try and find it in McKee, it says C neurothekioma. So, but maybe that will be different in a newer edition. But the
So, I mean,
WHO,
certainly in the drop down, what we've tried to keep is the correct what the current nomenclature is. But usually in brackets, we keep some of the older nomenclatures simply to allow the participants to find their diagnosis, isn't it? So I would be a little bit reluctant to take that away till it gets fully embedded and the term becomes completely obsolete. But if people are using it, and I think it's okay to keep it in brackets.
yeah, the last thing we want is for somebody who
Skin
knows
comma.
the diagnosis
Yeah,
not being able to find
exactly.
it. Yeah.
Absolutely. Okay, so what?
Site stated as left lateral nose.
Somebody needs to mute themselves. I think I know who it is. Muted them now. I can't see the chat. I'm sort of relying on you two.
So people commenting this is not cellular neurothekioma, that we agree. So that's a separate entity, isn't it? So Will commenting there's a thought that they are a type of schwannoma. Not many comments coming through. Naveen thinks option 1 is fine.
Okay.
It was quite a lovely example, wasn't it? Yeah, very nice. Again, thank you to the participant who's submitted this case. It
It's a
was
gorgeous
really nice.
case.
Yeah, absolutely. It's not something that we see very commonly.
Could probably go for the vote, I think.
Yeah.
Yeah, because we've got the other couple of cases a bit more tricky.
Okay, so we'll vote from schwannoma onwards. So
Yeah.
category
So
2
it's
onwards.
AL8. Yeah.
I think we have quite clear-cut response.
Yeah, I think we can end the poll. It's not
Yeah.
going to make any difference now.
Okay. So is it 0 for everything?
Looks like it, doesn't it?
Yeah.
Let's make sure. Yeah. All 0 apart from the initial diagnosis.
Yeah.
So everyone is recognizing this, it seems. Cool. Okay, next one. Oh, just to put a slide together. Can you see my share at the moment?
We're still on the table.
Okay, but you can see it. Right. Yeah, this is just the thing about it where we're at the moment. WHO not recommended to use the term neurothelioma, but it is still basically in McKee, and Whedon talks a bit about the historical confusion. So that's where sort of the books are going. And just in terms of the classical immunoprofile of this entity, so these are the stains that are supposed to be positive: S100, GFAP, NSE, CD57, S100A6, and you may get a bit of EMA in the adjacent fibrous tissue, whereas that's quite different to the immunoprofile of the classical cellular urothelioma. We'll look back at what happened with the GFAP, and I think it was just unfortunately one of those things. That's Eleni, do you want to say something? Yeah.
Apologies, that was something that I didn't realize happened. When the slide was, there was a, along with the immunosubmitted, there was a negative control, and that was scanned in place of the GFAP. And unfortunately, when it was picked up, it was after the circulation was closed. If anyone would go now to the link that was provided in that email, this has been corrected, but obviously it's too late, and apologies for those who were influenced by this finding if they only saw the Oxford platform. I was curious about GFAP positivity in the differentials and how, defining it is as a feature. I didn't have a chance to look into that.
Patrick, can you tell us about the molecular aspect? That sounds really interesting. Don't know if you can hear me, Patrick, but basically the comment is that it's got the same molecular signature as dermal schwannoma. I think that's really interesting. Right, we'll crack on. Next case, AL9, 36-year-old female, 4 mm darkly pigmented lesion on the right upper arm, starburst appearance on dermoscopy, question mark Spitz nevus, rule out melanoma, skin excision, actually even smaller on the macro. We weren't told anything about immunohistochemistry, and the submitting participants favored this as spindle cell nevus of Reed. This is the histology. Again, I probably used the RCPath portal for most of these images, if not all of them. You can see that it's only present in the right-hand section, and it's quite a small but darkly pigmented superficial melanocytic lesion. And there's some surface pigment elimination into the stratum corneum, a bit of sort of associated hyperplasia of the epidermis, some elongation of the rete ridges enveloping the melanocytic nests. We can even see at this power that there is a little bit of upward spread, probably mainly nest, but also some single cells, and even this impression of sort of a vertical orientation of the nests. It's quite well demarcated, relatively symmetrical. There is some inflammation in the dermis, and there's some pigment incontinence, but it looks like it's sort of mainly junctional, if not entirely. Here we can just see at higher power, there's definitely some upward spread here, single cells, and some sort of maybe some elimination of nests as well. We can really see the sort of vertical orientation of the cells, but it is difficult to see the cytology, and there's some comments about that, which I'll talk about in a minute, but because there's a lot of melanin pigment obscuring the cells. That said, you can see some nuclear detail, but it's difficult. It's also a little bit of a thick section, but we can see some melanocytes with vesicular nuclei and single nucleoli. I think we can see them sort of towards the right-hand side, but other areas it is really difficult to see the cytology. Here again, really quite difficult, but you can just about see some of the cells. I don't think we're seeing any sort of crazy looking cells here. There's no sort of wild cells, even though it's difficult. And this is the upward spread and pigment elimination and into the stratum corneum. This is the dermis. I don't think there's really any cells in there other than inflammatory cells and melanophages. just to contrast, this is the Leeds, bit more pink, the section here. Again, you know, difficult potentially to really see the cytology. I'm not seeing any huge nuclei, but it is tricky. This is the Oxford. Again, quite a thick, dark section. Again, quite difficult. So just thought I'd contrast that today, because we're going to be thinking about which portals and things. I'm just going to pick out some of the comments. So first of all, there's sort of a theme here with some of the comments that some would want like a bleach section to appreciate the cytology better, and some felt that they would work this sort of case out with more immuno. So interestingly, at the bottom, some comments about doing a BRAF here, IHC, or maybe a PRAME also, if you're thinking about differential of melanoma in situ. There were a lot of comments that felt this was just a good enough, typical sort of Reed, Nevis, Spitz ballpark. So yeah, many people felt they were happy with this. There was a different group of comments talking about this upward spread. It was quite prominent. But some said mostly in the lower half. They didn't want to put them off calling it a read, but they recognized that it was there. You could wonder if there's some trauma here as well because of the parakeratosis, which I forgot to mention. A lot of people were talking about the section quality here, really making it very difficult. And I thought this has got an interesting comment. The third one, likely benign, but it's a bit of an educated guess, more sort of weighing everything up rather than really being able to see the cytology very well. So this is the vote. It will be a scoring case. So the overwhelming majority were happy with calling this pigmented spindle cell nevus of Reed. We have lumped it together with pigmented spits in the EQA light. So that sort of solves that problem of whether you're going to call it Reed or Spitz. And then we didn't lump it in with ordinary benign Spitz nevus for the purpose of the voting. We thought we'd just keep it separate at the moment. We didn't want to make that decision as organisers, and would prefer the participants to comment upon that. And there were a few other diagnoses in there. For example, Pagetoid Spitz was in there. So people would need to think about whether they would think this is an example of that, whether there are atypical features to push it to an atypical Spitz, whether it's melanoma in situ. So I'm going to open it up. Comments?
Not many coming through. Richard feels it's totally academic as it's nicely excised, ultra low risk lesion. Alan thinks there's a great degree of agreement, which I agree, 95%, that's pretty good. Yeah, I suppose the main question really is what people would want to vote Spitz nevus as. Should that be getting the full score?
Andrew Boone says it's a nice example of a spindle cell nevus of Reed, so perhaps it would be a bit odd to select Spitz. Although, you know, it depends on your voting strategy, I suppose, if you're somebody who prefers to keep it broader. So yeah, it does depend on how you tend to respond to the EQA on the EQA light.
Yeah.
Mary says previously we've said Reed and Spitz are synonymous for EQA. I do recall something like that. I think a lot of people feel that 2 is not unreasonable.
Yeah.
If we consider that usually they have the NTRK3 and we consider NTRK fusions as part of the Spitz lineage, then I don't know clinically if a clinician said Spitz nevus whether they would want to bring it to a CPC, or if they heard Reed nevus, they'd be more comfortable that this is just what it is. But if it's Spitz nevus, would they wonder if it's nevus or something worse going on? So the management, would it be the same or?
Probably the same, isn't that?
I mean, what you put down on the EQA is not necessarily how you write your report. I think Arjun's got a comment.
Yeah, could we have I think we're running behind time.
Okay.
Yeah,
We've got a very interesting.
I just want to say, I agree that molecularly it's the same neoplastic proliferation of melanocytes. Now, historically and morphologically, if we have named them something different, it's time to recognize that they are molecularly the same neoplasm. Thank you.
Thanks.
Richard is suggesting maybe a lower score. Shall I launch the scoring now?
Yeah, I think so, because we've got another case.
We are just about, yep. So I think we are okay.
Yeah.
Yeah, that's fine.
There wouldn't be much difference. Okay, so I'm going to end the poll.
So Spitz Nevis gets a score of 1.
Yeah.
And everything else 0.
Yeah.
That's right.
Okay, thank you. Yeah. I'm sorry, Salim, I think we're running behind time, so maybe the last case will have to be a bit quicker, although it's quite an interesting.
It's quite a complex case, but we'll
Yeah.
do our best. Yeah.
Okay.
I think there's quite a lot of education in this case. Just the only thing I want to say about this is there's this nice paper looking at spindle cell nevus of Breed and reed-like melanoma if you're looking at that differential. And basically, these reed-like nevus that are well recognized now to the NTRK3, which we heard about, contrast that with the reed-like melanomas. They're pretty much all BRAF. So it's a really nice little tool. BRAF IHC for this sort of case can help unpick that. And the older patients as well. So that is a good paper just to be aware of. Right, AL10, 76-year-old female. The clinical was question mark sebaceous adenoma, question mark tumor with sebaceous differentiation, question mark epidermoid cyst, excision from the forehead. We were provided with a Ki-67. The favored diagnosis from the submitting pathologist was sebaceous carcinoma arising in a sebaceoma. Here's the low power. Slightly different sort of top and bottom, but basically we're seeing a dermal-based tumor sort of pushing into the subcutis, but not actually invading in any infiltrative manner. And we can see this sort of variable solid and cystic elements. This is one half the section. We can already recognize at this power that's going to be a sebaceous tumor with some components which have quite a lot of mature sebocytes and other areas which are more basaloid. On the whole, relatively well circumscribed. It does appear to be arising in skin of sun-damaged skin with some solar elastosis. This is the sort of the more sort of mature element, quite closely resembling sort of mature sebaceous glands, but with a thickened basaloid compartment. And this is the cytology from these sorts of areas. So there's definitely sort of a basaloid cell population with vesicular nucleoli adjacent to mature sebocytes. Relatively uniform cytology and low mitotic activity in those sorts of areas. Here's a more mature area adjacent to it. This is down at the bottom in one area. Similar sort of cytology. There's a little bit of microcystic change and ductal change there. Similar sort of cytology, relatively uniform. And then we had a more cystic area. I'm just going to let people really look at the cytology because that's really what the case is partly about. There's a little bit of mitotic activity in this area. The cells are still relatively uniform, maybe some mild pleomorphism there. Yeah, there's the mitoses. The immuno was really quite interesting. We were provided with the Ki-67 because you could see some areas of tumor with distinctly higher proliferation on Ki-67. On the top section, we've got that smaller nodule to the bottom right. And then on the lower section, this more cystic lobule. it's, definitely a higher proliferation. If you just look at the difference here in that smaller lobule to the bottom right compared to the adjacent areas, you could have sort of guess at what the proliferation rate is, but it's certainly higher than the rest of the tumor. And what I did is just to compare the cytology. So on the left is that nodule, bottom left. Compare the cytology with the lower proliferation tumor areas, bottom right, and decide if you think that's much different or not. I'm not going to tell you what I think. I'm just going to let people look at that. And I'm sure you would have done this at the time. Comments, sort of broad range of comments. So this is a whole sort of snapshot of comments where people felt this was a sebaceous carcinoma arising in sebasioma. So basically a whole cohort of comments in that way. And the Ki-67 certainly influenced some people in coming that way. Interestingly, some people are calling this low-grade sebaceous carcinoma to try and emphasize that maybe the behavior wouldn't necessarily be too concerning. On the other hand, there were whole different comments going the other way, even irrespective of the Ki-67, that would push them to still calling this benign and allowing for that high Ki-67. So just to recognize two different groups of comments. There's a little bit of comment at the bottom there about whether is it a sebaceous adenoma if you felt it was benign or a sebasioma, depending on whether you think there's more or less than 50% of the basiloid compartment. And then there were another group of people that were sort of recognizing the difficulty of this case and wanting to call it either an atypical sebaceous neoplasm or this other thing at the bottom, sebasioma with a proliferative nodule. So some people sort of trying to recognize the intermediate sort of idea. Then some people talking about the role of immunos, and in addition to Ki-67, P53 was mentioned, which of course we weren't provided with here, and there is some literature on this. People talking about the architecture again. Some people wanted some other immunos as well, but P53 was possibly the main one that was mentioned. And then finally, some comments about thinking about in the back of my mind, Muir-Torre syndrome. And this was a cystic looking tumor, for example, which can be a feature. So that was sort of the snapshot of comments. And that was the voting that we had. So as it stands, it might be tricky to get to a 75% here because we had really quite polarized views on sebaceous carcinoma versus benign. Really quite interesting. As I say, the favored diagnosis of the submitting pathologist was malignant argin.
Hi, I think I just wanted to say this is a classic example of where conventional terminology and standard boxes clashes with more fundamental pathology. So we can imagine from first principles that sebaceous tumors will fall into benign with low proliferation, low rate of proliferation, so they stay stable and good differentiation. Then you get proliferative sebaceous tumors, which is what we would traditionally call sebasioma, and that proliferated neoplastic proliferation could be stable or unstable. Unfortunately, it's unstable only in a rarity of cases, in which case we see morphological heterogeneity within the lesion. So that's a criteria to be careful of. And if you see an asymmetric morphological heterogeneous subpopulation, then to hone in on it. And yeah, then where do we draw the distinction between an atypical proliferation within a proliferative sebaceous tumor / sebasioma versus in situ versus nodular sebaceous carcinoma, and all to be distinguished from the high-grade sebaceous carcinoma. Thank you.
Thanks.
Salim, just a point. I think there is a category 6 and 7 as well.
Oh.
That's just sebaceous trichofolliculoma and atypical proliferating pillar tumor. It's there in the poll. So
Yeah.
okay.
Okay. Sorry about that.
So just don't worry. Yeah, I think it's a great example of almost a 50-50% split, isn't it? If you look at all of the other categories, they're all benign. And of course, we've got sebaceous carcinoma at 55%. So, but I think you highlighted all the difficulties with this case very well in your presentation. not an easy case.
I think there's certainly some comments suggesting we need to vote on whether it's even scoring.
Yeah.
Yeah.
I think this is a good example. That would be best to do that. And there's a lot of interesting comments about immunos and use of P16, for example, is useful. Richard thinks there was P53 that we allowed mitoses in benign sebaceous tumors. But basically, I think we're going to have to vote on whether it's scoring or non-scoring.
I agree.
Okay. So have we got any more? Yeah.
Yeah, and I think just to clarify, I'm just thinking about this. So in the case of pityriasis rosea, that was different because there, if it is probably better to give a differential and then go back to the clinician, and that's resolvable with appropriate CPC. But in a case like this, there is no point of giving a differential in your final histology report. So you would have to pick one or the other. So a case like this, perhaps in the EQA setting, is more of a non-scoring category because it's just a very difficult case or something which doesn't lend itself to a very clear-cut diagnosis. So I think in this case, asking the group whether this is scoring or non-scoring would be helpful.
Okay.
Should we go for the poll? Yeah.
I think let's launch that. Yeah.
Did it launch?
Not yet.
No.
Because it seems to be difficult to.
Strange.
Yeah.
We're doing AL10, aren't we?
Yeah, but scoring, non-scoring.
Oh yes,
So I think we've run out of.
have we? Thought we had loads of those. Oh, I found one.
You found one?
Yeah. Oh, it won't let me launch that. Okay.
Yeah, that's the problem.
Shall
I do a new one?
What's happening?
Why
Very
is that
strange.
happening? Yeah. Yeah, it's
That's
not allowing
bizarre.
you to. A poll result is being shared. Something is being shared in the meeting at the moment. Can you just go to close down all your polls?
I can't
Yeah,
see.
if we've got any polls open, this seems to be the problem.
Oh, okay.
I'm not sure it's me.
Can't see anything on my screen being shared. That must be me. Then close the poll option completely. Did it go now? No.
Oh dear.
Well, that's odd. We'll have to do it by raise of hands. Okay.
I'm not sure what's happened there.
Yeah.
Does it still show? It doesn't show on mine.
So all three of us, the option of launching the poll has disappeared suddenly.
Oh gosh. Okay.
What do we do?
I have the option of, but it doesn't let me launch.
Yeah, it's same with me. It's
okay. I'm gonna try and create a new one.
I think the main problem is that
it thinks that we've got
sharing
a poll open.
I don't see that.
Me neither.
So
That's really weird.
Non-scoring.
When I click on polls, I see that AL9 is open.
Oh, okay. Let's try and close that then.
How was that?
It says ended online.
Yeah.
Let's try now. Oh, it's letting us do it now. Yeah.
Okay, great.
Perfect. Thanks for all spotted. Yeah, it's non-scoring.
Yeah.
Yeah. I think I'm getting a clear response.
Okay.
So definitely non-scoring.
Okay. Someone was asking if people would do a Ki-67 in a case like this.
That's interesting.
Which is an interesting point.
I have got some education on this, which is very quick.
Okay, should we have that first and then we can take comments from the group? We've already actually run above time, so a short
I'll keep it very quick. It's pertinent. Just to talk about this thing, the actual thing about sebaceous carcinoma arising from a pre-existing one, which is what we're talking about here. It looks like it's vanishingly rare in the literature. Obviously, sebaceous carcinoma is not that rare, but this specific thing. So I've been interested in this area because we've had a case. So this is one case report. So we're only talking about handfuls of cases. And this was their case from this paper. And if you can see where they think the sebaceous carcinoma is on the top left, they think it's only a small portion of that tumor. So that's a really tricky case to say that bit's carcinoma versus the rest being benign. But that was that paper. So we looked at that paper and found it quite difficult to understand. We have had a case in Dorchester, which we published, where we argued it was this scenario, and we had used immunos on this, and we found the P53 was quite helpful. And this was our case where we found there was a small component to the top left we felt was the benign component, and then there's this much bigger area which was quite cystic, and we felt there was a bit of difference in cytology. If you look at the bottom left, it looks more organized. It definitely looked more disorganized on the right with more mitoses. And this was the immuno.
It's an all-day meeting, so
yeah, let's put on mute. So this was the immuno we had, and there was a massive difference in terms of the P53 in A top. It was wild type. In the top right, it was distinctly null. So it suggests there's a P53 mutation in that larger area, which we favored as carcinoma, and there was a big difference in the proliferation rate with the Ki67. So for what it's worth, it got accepted, that paper. You can still debate whether you agree with the diagnosis. We haven't got time to go into this, but I just want to signpost you to one more thing, which is this sort of group here. They've alluded to this problem of these nodular tumors, which, they're quite high in proliferation, but they're so circumscribed. This is the sort of cytology in that paper. And the bottom line is, whether you feel there's a carcinomas or not, they seem to have very good behavior. They seem to have very good behavior in this paper. So, this concept of a low-grade sebaceous carcinoma, I think that would help the clinicians, because we're not talking about things where we're worried about, significant metastatic risk, but potentially even in these sorts of tumors. So just to be aware of that out there. And you might think about calling these atypical sebaceous tumors rather than actually malignant. I have got a few more slides, but I'm not going to go into all those. I think that was the main concepts I wanted to bring in. But I know there are some comments as well, which probably we should take as well.
I was actually thinking maybe, normally we have some educational cases, perhaps in the next round, because Richard was mentioning he's got some interesting ones. Maybe you could have one or two educational cases and a bit more in-depth discussion on this. We really have run completely over time, and this will skew the rest of our day. So I do apologize, but I don't think we can take any more comments for now. So thank you everyone very much. Thank you, Salim and Eleni, for those great presentations. Should we take a break now for 10 minutes maybe, and then come back at 11:25?